Thank you for joining Cancer Support Community Atlanta for Frankly Speaking About Colorectal Cancer, facilitated by Dr. King-Mullins with Georgia Colon and Rectal Surgical Associates. If this is your first time participating in a Cancer Support Community Atlanta program, we invite you to visit our website and complete a new attendee form to stay connected to all future programs. Welcome everyone to Frankly Speaking About Colorectal Cancer. I'm Katie Armsby, the Program Outreach Director with Cancer Support Community Atlanta. If this is your first time participating in a Cancer Support Community Atlanta program, we do invite you to visit our website, cscatlanta.org, where you can see all the free oncology support services offered virtually, which does include a monthly colorectal cancer support group as well as a monthly caregiver support group. Everyone will remain muted for the duration of the program, but we do invite you to enter questions into the program chat box, which Dr. King-Mullins will address during the Q&A at the end of the program. I want to welcome our presenter today. Dr. Erin King-Mullins received her medical degree from Emory University in Atlanta. She then completed her internship and residency in general surgery at the Orlando Regional Medical Center in Florida. Dr. King-Mullins went on to complete her fellowship in colorectal surgery at Georgia Colon and Rectal Surgical Associates and subsequently joined the practice. Dr. King-Mullins is board certified by the American Board of Surgery and the American Board of Colon and Rectal Surgery. She's also a fellow of the American College of Surgeons and the American Society of Colon and Rectal Surgeons, where she serves as an active committee member. Dr. King-Mullins currently practices at Georgia Colon and Rectal Surgical Associates and sees patients at their Midtown and Sandy Springs location. And with that, welcome Dr. King-Mullins, and I'll go ahead and pass it off to you.
Well, good morning, everyone. Thank you so much for joining us on today. Thank you, Katie, so much for that wonderful introduction for the Frankly Speaking About Colorectal Cancer presentation on today. I need to start off by saying I don't have any financial relationship with any sponsors of this program. And I really want this to go forward more as of a conversation. We will be discussing several topics with regard to colorectal cancer. So feel free, if you think of any questions or anything, write them down. We will be going over a lot of questions at the end, and I will do my best to answer them as best as possible. So here's just a picture of our practice. We have we will have one more joining us here soon, but we have 6 colorectal surgeons, we have 7 offices, and we cover 7 locations within the major metropolitan Atlanta area. So we're probably close to you if you're anywhere near Atlanta. So just a quick program overview. First, we're going to talk about some basics about colorectal cancer, just to lay some groundwork. But this is not designed to be a study in anatomy or a science lecture, really just to lay some groundwork, because it's very complex moving forward when someone is diagnosed with colon cancer, how you interact with your medical team. So we'll discuss how you partner with your medical team. We'll discuss how you manage some of the side effects and kind of some of the hiccups that may come along the way as you're being treated. And then coping with life after treatment, just, things for not only the patient, but their caregivers, some resources so we can discuss how to move forward, because this is a very life-altering situation and it's a very long road. So understanding colon and rectal cancers. So just some basics. Colorectal cancer begins as a polyp in the colon. So anywhere in the colon or rectum, and this typically is not necessarily identified by the patient when it forms. So colorectal cancer is the 3rd most common form of cancer in men and women in the United States. Fortunately, over the past 20 years, the number of deaths from colorectal cancer has gone down as we have been able to better screen and diagnose and treat the cancer. But for some reason, we're seeing a rise in patients under the age of 50 that we haven't quite figured out just why as of yet. But we do know that screening for and removing polyps is the best way to cure or prevent colorectal cancer before it even arrives. So currently, the recommended screening age for colorectal cancer is the age of 45. And I'm going to take a minute and describe what screening is. Screening means that you are detecting something before it is visible, before it is symptomatic. And so when someone's getting a screening colonoscopy, that means they don't have any symptoms whatsoever, but they're undergoing the test because they have a risk of having a cancer or polyp. So we recommend at the age of 45, because above that age, there is a good likelihood that a polyp could be found. So it's very similar to why women will start getting mammograms after a certain age. Men will start getting prostate exams after a certain age. We just know that age plays a role in developing these problems. So again, like I said, many people will have no symptoms at all. And so if you've been diagnosed, we encourage you to tell your friends and family, especially if they're of age, that they should start get screening too, because again, you may not have any symptoms. Here on the screen, you'll also see some common symptoms, but by no means is this list exhaustive. So a change in bowel habits, meaning you're typically regular, but maybe you go more frequently. The stool caliber, shape, size, color can change. Those can be indicators that there's a problem going on. If you notice blood in the stool, abdominal discomfort, losing weight for no apparent reason, constantly fatigued, vomiting, those are some things that can trigger that something may be going on and that you may need to be tested. So what are our risk factors for colorectal cancer? As we previously mentioned, age, a family history of colon polyps or colon cancer. Sometimes there is a genetic inherited syndrome that's going on. A personal history of polyps will put you at risk for having colon cancer in the future. And that's why once you've been diagnosed with colon polyps, you will need to get your regular scheduled colonoscopies on a more frequent basis than the average person. And if someone has a history of Crohn's disease or ulcerative colitis, that also places them at increased risk for colon cancer. So the factors that I just mentioned are things that you can't control, your doctors can't control. But the following risk factors, diet, smoking, lack of physical activity, and obesity, these are what we determine are modifiable risk factors. These are risk factors that we have control over that in varying degrees can contribute to the formation of polyps and cancer. So we should try our best to be healthy so that we can limit these risk factors. So how do you diagnose a colorectal cancer? Well, our favorite approach is the colonoscopy. We say that because it can be diagnostic and therapeutic. So the procedure is an outpatient procedure done at the hospital. The patient typically receives some sedation medicine, and a camera is utilized to look throughout the colon for polyps, tumors, signs of bleeding, masses, and the like. The good news is that if a polyp is identified, it can be removed right then and there. And that's why we say it can be diagnostic and therapeutic. It can treat that. Whereas other tests, such as the stool tests and imaging tests, they will detect an abnormality and have to be followed up with a colonoscopy to verify whether or not something is truly there. So another test, stool tests, where you submit a stool sample, that will look for blood or potentially special cancer DNA in the bowel movement. Again, if these tests come back abnormal, a colonoscopy has to be performed to follow up to ensure that there is something there and to diagnose it and to potentially treat it. There are some imaging tests that are utilized to help diagnose and stage cancer. So there are things such as a virtual colonoscopy or and this is performed by a CT scan or an MRI. The shortcoming of this is that it is not therapeutic. So again, you may be able to identify a polyp, but you can't do anything about it and will have to follow up with a colonoscopy to treat it. Imaging tests also come into play when someone has already been diagnosed with cancer to understand the extent of the disease and whether or not there's any sign of spread to anywhere else in the body. So some of these tests can include a CT scan, an MRI, an ultrasound, or a PET scan. You'll be discussing this with your physician, which would be best for you in your situation, should this arise. And then surgery. Surgery is designed to remove the tumor, the surrounding tissue, and the lymph nodes. All of these will be sent to a pathologist to be tested, again, to help figure out the stage of the disease. Very rarely, someone will have an abnormal CT scan and they're not able to get a colonoscopy and you actually have to proceed with surgery because it's causing a problem like a blockage or bleeding, and then you actually officially diagnose a cancer that way with surgery, because a colonoscopy sometimes, in some instances, is not possible. So what are the stages of colon cancer? So I'm going to jump forward a little bit to this diagram. So there are stages. Stage 0 is technically a polyp. It actually has not formed into cancer. It has not, in this picture, gone through the wall of the colon. So this is great as far as why we do screening, again, to prevent and cure colon cancer before it starts. Stage 1 means that it's growing into the wall of the colon, but the tumor is not larger than 2.5 centimeters, which is roughly 1 inch. Stage 2, still just into the wall, but the only difference between stage 1 and stage 2 is that stage 2 is larger than 2.5 centimeters. Things have still not progressed to the lymph nodes. Stage 3, as you can see with the green circle in this picture, means that the tumor has progressed through the wall of the colon and is now going to the lymph nodes. Stage 4 means that the tumor has spread beyond the lymph nodes and has gone somewhere else in the body. And this is what we term as metastatic disease. So now you've been diagnosed. What do? So many things come afterwards. You have to partner with your medical team and come up with a team that works best with you. So successful treatment requires several people. And it varies depending on whether or not you truly have colon cancer versus rectal cancer and the stage of disease. So your team may consist of a surgeon, a medical oncologist, a radiation oncologist, an oncology nurse specialist, social workers, nutritionists, patient navigator, a pharmacist, primary care physician, but most of all, you. And your choice of your medical team really depends on a combination of your preferences and, again, your official diagnosis. For example, radiation typically only comes into play for rectal cancer. So if you've been diagnosed with colon cancer, more than likely you won't have to interact with a radiation oncologist. But also, depending on where you live, the recommendations you get from friends and family and colleagues, the style of communication, the location of your physician, whether you're looking to go to a specialized cancer institution or whether or not you're looking to go to your local institution, your insurance level, and various other preferences, that will play a role in where you are treated. And so be very forthcoming in what your goals and expectations are, because this will definitely play a role in how your team will develop. So be prepared for your appointments. If you're experiencing anything, be sure to tell your doctor about side effects or symptoms that interfere with your life. Tell your doctor about any medications or herbal supplements you might be taking. When you're away from your doctor and you can't get with them immediately, be sure to write down any questions or concerns that you have and learn the best method of communication, whether that be via telehealth visits, email, scheduling an in-person appointment. Find out the best way to keep in touch with your physician and your team. This is key. Bring a friend or a relative that you're comfortable with to your appointments. Obviously colorectal cancer can be very devastating and it's a very overwhelming process. So having an additional set of eyes and ears is very important to make sure that you understand and that you're comfortable with everything moving forward. And then whenever you receive a test or a blood test or an x-ray, please be sure to ask your physicians for copies of these results, because although we try to communicate with other physicians as best as possible, sometimes faxes don't go through. Sometimes there are delays, there's out of office, especially a surgeon may be, doing surgery. So take whatever copies you can to your specialist so we can make sure everyone is informed of what your latest results are. Consider having a second opinion. It is your right to have a second opinion, and please do not feel as though you are offending the physician. Again, you have to feel comfortable with your medical team, and so it's very common, it's very accepted to get a second opinion, and sometimes even in certain situations, a third opinion. So while there is no one exact right way to treat colon cancer, there are very specific guidelines and standards of care based upon your diagnosis. And so you want to make sure that your team, your physicians are operating within that standard of care, but sometimes things have to be individualized based on your official diagnosis and your social situation. So making treatment decisions with your team. So at the outset, you have to understand what your goal of treatment is. The goal of treatment for someone with a stage 1 cancer may be very different than the goals of treatment for someone with a stage 4 cancer. So the goals may be to remove the cancer cells, it may be to kill the cancer cells, or it may be strictly designed at stopping and slowing the growth. So be very sure that you discuss this at length with your oncologist so you understand what your treatment options are and what are reasonable goals for your treatment. Everyone responds to treatment differently, so communication is key. So in discussing the types of treatment, the mainstays of therapy are surgery, chemotherapy, and radiation therapy, and we'll go into those a little bit. Things that you may hear are immunotherapy, biological therapy, clinical trials. You may see these advertised, throughout your medical facility, even sometimes on television. These are not the mainstays of treatment, but do come into play with certain situations, with certain types of tumor. So if this arises, be sure to discuss this with your physician if any of these are right for you. So surgery. This is the mainstay of treatment when possible. The goal is to remove as much of the cancer as possible. Now, sometimes patients may require a colostomy or an ileostomy, which are forms of being able to pass stool into a bag during the time of treatment. This bypasses part of the colon. Sometimes it's a temporary thing to allow for healing. Sometimes, depending on the location of the tumor, this may be a permanent thing. But by no means does this prevent you from being able to continue a completely well and active life. It's performed more often in rectal cancer than it is in colon cancer. But again, it's not always necessary. It is purely on a case-by-case basis. So chemotherapy, there are two types. Adjuvant therapy is given after surgery. For example, if there's cancer cells that are found in the lymph nodes, this therapy is utilized to, I say, a mop-up job. It's kind of to clean up any residual cancer cells that may be floating around the body that aren't being able to be seen on a CT scan or X-ray or ultrasound. Neoadjuvant therapy is much more common in rectal cancer and is typically utilized in combination with radiation therapy. This is therapy that's given prior to surgery. Sometimes it's designed to shrink the tumor. Sometimes it's designed to control bleeding or control pain. Again, radiation is targeted to the tumor itself and sometimes to the tumor bed after surgery. If sometimes the tumor is very large or if it's seen to be invading nearby structures, radiation is used to then control and kill those remaining cancer cells. Radiation can also come into play when we're dealing with metastatic disease. So what affects our treatment decisions? A lot of that really depends on the type and stage of your disease, the results of biomarker testing. This is typically done once a tumor has been removed. The tumor will further be tested for biomarkers. Your age and your overall health plays a role. Other medical conditions you may have. For example, patients who have Crohn's disease or ulcerative colitis may not be the best candidates for radiation therapy when it comes to rectal cancer. Whether or not you've had radiation, cancer, or treatment or chemotherapy in the past plays a role. There's certain levels and amounts of certain drugs that your body and radiation that your body is able to tolerate. Your response to certain treatments, and your willingness and ability to move forward with certain treatments. Definitely your home life and your social life plays a huge role in deciding what's going to be most comfortable for you and able to move forward. So this is a very busy slide, but this just goes over all of the follow-up that will be done. So typically, once someone's been diagnosed and treated with colorectal cancer, they're followed on a regular basis with visits in the office, blood tests, CT scans, colonoscopies for at least 5 years. So once someone's been treated and there's no sign of tumor in the body, they're considered to be cancer-free. But someone's not considered to be cured of their cancer until year 5. And so that's why we do all of these testing on a regular basis. So one big fear once someone's been treated and the cancer's gone is an obvious fear, a fear of recurrence or a fear of the tumor coming back. So the keys are to be informed, keep with those regular scheduled appointments, talk about it with your medical team, allow yourself to feel up and down. It's healthy and normal to feel sometimes negative emotions. And don't let anxiety and fear prevent you from seeking medical care. So if something's not quite right and you have a fear that maybe the cancer is coming back and it's not quite time for your follow-up appointment yet, don't be afraid to reach out to your medical team and see if there's an additional testing that can be done. So let's talk a little bit about managing some of these side effects. So having information about short-term and long-term side effects before, during, and after your treatment will help you prepare. So whenever you're starting and embarking on a new medication for chemotherapy or embarking upon the need to have surgery, ask all your questions. And sometimes it's important to ask, what should I be worried about? And that's perfectly safe and okay question to ask. You may not experience any side effects at all, but by asking about potential side effects before treatment, you'll know what to look out for. And sometimes you'll know what's to be expected and what's normal, and so you won't have to fear at all. So some of the side effects from surgery are the initial pain and risk of infection immediately surrounding the time of surgery, scar tissue, adhesions. Sometimes this leads to having further surgery, fecal incontinence or leakage. This typically plays a role when we're dealing with rectal cancer and where discussions about potentially having a colostomy or an ileostomy comes into play, because fecal incontinence can be very life-altering and can severely affect your quality of life. And also sexual dysfunction. It's important to have these discussions with your physician as well. You're still human. You still have a life that you need to live. So this is a comment from a colon cancer survivor. If I hadn't had a colostomy, I wouldn't have lived. It's what you have to do to survive. It doesn't limit me in any way except for not wearing extremely tight clothes that I wouldn't wear anyway. So some of the side effects of chemotherapy can include diarrhea, mouth sores, hand-foot syndrome, neuropathy, fatigue, hair loss, changes in your blood pressure, rash, bowel perforation, allergic reaction, nausea, vomiting. Again, some people have no side effects at all. Not everyone is going to have every side effect on the list if you do experience side effects. So again, just be alert and in tune with your body, and if you experience anything different, discuss this with your medical team. Side effects of radiation. So patients can have burn-like skin irritations. It can range from the level of a mild sunburn or a very severe burn. So if you're experiencing pain and swelling, discuss with your radiation oncologist. Sometimes they need to pause treatment and resume it later. Sometimes they need to prescribe certain creams to help combat the burning and irritation, but don't be silent. Pain and swelling, scarring or blockage of areas, incontinence, and sexual dysfunction can also come into play with radiation therapy as well. So another message, make sure to let the doctors know your comfort zone. If you're experiencing pain, tell them how intense it is, because if you're in pain, you can't concentrate on the sickness and getting better. The doctors don't want us to be in pain if we don't have to be. And that's very true. So don't feel like you're not able to comply with treatment if you're having pain. Sometimes, if you're having too much pain or having too much of a side effect, that's going to lead to you wanting to stop treatment, as opposed to there may be the ability to modify treatment so you don't have to stop treatment and you can continue being treated for your cancer. So survivorship, what happens afterwards during the diagnosis, after you've had surgery, when you're on the path to recovery? So your quality of life is very important. Living with colorectal cancer can be one of the most challenging life events you and your family will ever face, physically, socially, and emotionally. Feeling sad, alone, angry, anxious, overwhelmed, or distressed is very common. Please allow yourself to feel those emotions. And caregivers often feel those emotions and should feel those emotions too. Know that it is possible to find some sort of balance between your medical concerns, your relationships, your self-esteem, your body image, your work, your finances, and other responsibilities. And that's where your team comes into play. There are different case managers and social workers and everything that can help with some of those other ancillary issues other than your dedicated medical treatment. Keep communication open and honest. Find people in similar situations for support. There are support groups out there. Talking about colorectal cancer can be challenging, and so sometimes it's very hard to discuss it with your friends and your family if they're not experiencing what you are. But finding a support group or finding someone who's been through similar things is very important to help you understand what is normal and what's not. And if you don't want to talk about it, write it down. Keep a journal and use it to share your emotions with your loved ones and your doctor, maybe at a later time, or maybe you just want them to read it so you don't have to, say it out loud, but that's also a very good way to communicate your feelings and your emotions. It's a private matter, but once you realize that so many other people are affected by cancer and share the same feelings with you, you feel a sense that it's worth talking about. So sadness, grief, and anxiety are normal reactions. However, if you find that they're interfering with your ability to carry out normal daily functions, you should seek professional help. So if you're concerned about depression, here's some questions that you can ask yourself or ask the loved one. Do you cry often or uncontrollably? Have you lost interest in that used to give you pleasure? Are you eating? And if you're worried about anxiety, are you feeling nauseous or experiencing an escalated heartbeat? Those can be signs of anxiety, and especially the feeling nauseous or experiencing an escalated heartbeat. Sometimes it's the anxiety manifesting and not necessarily a side effect. So again, it's very important to discuss this with your medical team so they can differentiate what the problem is. So reach out and find support. Support groups have been shown to decrease the amount of depression that patients feel, increase their zest of life, and give them a new attitude towards their illness. Different forms of support exist. It can be one-on-one, it can be group therapy, it can be spiritual counseling if you are a member of a religious group. It can be advocacy. You can advocate on behalf of other future patients. If you experience certain side effects or certain negative experiences, you can advocate for future patients to not experience the same thing. So again, support groups can help you learn from others, feel less alone, and manage some of those side effects. Different types of support groups. So there's different support groups, maybe just for ostomy support. So you may have patients that are there with colon cancer, Crohn's disease, ulcerative colitis, or you may want to focus on a support group with all cancer patients. There are support groups for caregivers as well. And this can be done face-to-face or online. So strategies to keep yourself well. Physical activity is a must to keep the blood flowing, keep the body strong, and it also helps to prevent some of those depressive mood and anxious thoughts that you may have. Healthy foods help maintain your energy, help strengthen your immune system, and so you can ask for a consultation with a nutritionist to help focus on foods that may be important for you to eat to maintain your health during this time period. Be sure to drink plenty of fluids and keep your body hydrated. Pamper yourself. Don't forget to live. If there's something that you enjoy doing that you're able to do, by all means do so. Discuss it with your physician if it's reasonable, if it's a certain physical activity, especially if it's a rigorous activity. But again, find those things that you know lead to your mental wellness. And a special note on sexuality. Sometimes people are very afraid to bring this up with their physician, but again, people have lives and your sexuality is a very important part of your life. And it doesn't necessarily mean sex or sexual intercourse, because sometimes you may feel uncomfortable. Some patients feel uncomfortable with their body or their figure after having surgery or with having an ostomy. So please be sure to reach out to your physician and your medical treatment team if you have any questions with regards to this. So tips for caregivers: be sure that you take care of yourself. MyLifeline.org is a website that can help with scheduling and communicating with friends and family and talking to your loved one's healthcare team. And sometimes you need to reach out to other caregivers to find out pros and cons and how to break through and discuss and have a relationship with your loved one who may be having a little bit of a difficult time with their diagnosis and don't really know how to talk to you. So I'm going to turn things back over to Katie for a moment so she can discuss some of the things that come through and that are helpful with the cancer support community.
Thank you, Dr. King-Mullins. I do want to bring attention to Cancer Support Community Atlanta's virtual program on advanced care planning that will be taking place Tuesday, July 14th. And that conversation will be facilitated by Dr. Syed, Palliative Care Medical Director with Northside Hospital. And if you're unable to attend that live program, you can always find the recording on our website at cscatlanta.org. And also available on our website is additional information on stress reduction programs that are being offered. So we have some chair yoga, gentle yoga, also some gentle exercise programs, monthly nutrition seminars that are facilitated by an oncology dietitian with Northside Hospital Cancer Institute, and education programs like these. If you're unable to make any of those live programs, you can also find videos on our website. Support groups continue to be offered and have taken virtual platforms, and you can find more information on our monthly colorectal cancer support group again on our website, or you can email our program director, Emily Brown, at emily@cscatlanta.org. Another great resource is Northside Hospital Cancer Institute's website, where you can find information on screenings and also on open clinical trials and how to connect to those. And I think we'll go ahead and go to the Q&A portion. We got a lot of great questions that were entered into the chat box, and the first one I'll give to you, Dr. King-Mullins, is colon cancer hereditary? And is there a test I can get to see if I'm at risk, because I do have a family history?
About 10% of colon cancers are hereditary. So for all the patients that we diagnose, only 1 in 10 of them have a previous family history of colorectal cancer. So that's why it's very important for patients to get screened after a certain age, because 90% of the cancers that we find are what we call are sporadic, and they just arise from various other risk factors or just age.
Okay, great. And another participant asks, is there a specific way to prepare for a colonoscopy if you're on blood thinners?
Sure. So typically the prep itself, meaning the flush that you have to take, the laxatives, that doesn't change based on the blood thinners, but you have to be in communication with the physician that prescribed your blood thinners, as well as the physician performing the colonoscopy, to understand when and if you need to halt that medication prior to, because different medications will stay in your system longer, and depending on the medical reason for which you're on the blood thinners, sometimes the risks outweigh the benefits from stopping it. So that's a personalized conversation to have with your caregivers to understand if and when you should stop your blood thinner.
Okay, I think that's important to know. That's a good point.
Yeah.
And then I guess this speaks a little bit to the previous question. What preventative steps can be taken if colon cancer is in your family?
So we discussed a little bit about those modifiable risk factors, meaning, diet, physical activity. But the best means, once you have a family history, that's now your history. And so starting your screening at your scheduled time. And one thing that of note, if you have a family history of colon cancer, you sometimes have to start your screening earlier than that age 45. For example, if someone in your family is diagnosed at the age of 50, then you actually have to start your colonoscopies 10 years prior at the age of 40, so that we can catch things earlier and prevent things. So that's a good discussion to have, and make sure we have our discussions with our family members, because again, once someone in your family has been diagnosed, that's a part of your history, and you can help save lives within your family by having those discussions so people understand when they should start their screening.
And do you feel like the at-home screening are as useful as colonoscopies, or what are your thoughts on those?
There are definitely some pros and cons. It has its values. Again, it's one of those things you have to consider your overall risk, again, if you're, for example, that question about blood thinner, if you're a person who really shouldn't go off blood thinners no matter what, and there's really no good way to perform a colonoscopy, then having one of those tests might be beneficial, because if it comes back positive that there's something abnormal, then you and your physician staff, your medical team, the hands are a little bit forced now to proceed with the colonoscopy because there's a risk of something being there. But one of the caveats I have to tell all the patients is that, if that test comes back positive, that's not definitive that you have a cancer or a polyp. A colonoscopy has to be done to follow up to ensure whether or not that was truly a positive test. And so it varies from person to person, and you should discuss it with your physician if you're a good candidate. We always recommend, if someone is a good candidate for a colonoscopy, that they go ahead and proceed and have that procedure done, because it can both be diagnostic and therapeutic. And if you don't have a family history and your colonoscopy is negative, you're good for about 10 years before you have to repeat it, unless you have a problem, which those stool tests have to be done more frequently.
Okay, that's good to know. And this is going back to a little bit earlier in the presentation regarding a colostomy bag. Is a colostomy bag implanted in the bowel or stomach area?
So it's typically somewhere on your abdomen. It's usually about 2 centimeters or smaller in size, and it's a bag that will empty your bowels, and typically it can be very discreet to wear it under your clothes. And we get you partnered with special wound care ostomy nurses who, if we know that an ostomy is going to be required beforehand, we actually have you consult with them in advance so they can help pick an appropriate place on your body where it can be most discreet and comfortable. But they go through the process with you, and they can instruct you on how to use it and empty it, but it's typically somewhere in the lower abdominal area.
Okay, and this question, are there any indicators to know when chemo and radiation are working?
So you and your body may not feel necessarily any different, and so follow up with your physicians. Will typically order certain scans or blood tests. It can be a CT scan, an MRI, an ultrasound, or a PET scan. That's how you find out whether or not the body is responding. For example, radiation therapy continues to work for several weeks to months after your last radiation dose. And so typically there's a lag time, a period between when you get your last dose and you get your next x-ray or ultrasound, because it can still continue to exert effects for a while. And so that's how you find out whether or not it's working.
Okay, and this question is also related to radiation. I'm interested to know if you've had any experience with Xylota combined with radiation, and if you have any advice for someone starting that new regimen.
I see. So yes, Xylota is a chemotherapeutic drug that is sometimes used in combination with radiation up front to help sensitize the tumor so that it better responds to radiation. So I have seen patients and experienced patients who are undergoing that therapy. As I'm not an oncologist or radiation oncologist, I don't prescribe those medications, but sometimes patients can experience some fatigue. They can experience some numbness and tingling in the fingers or the toes. That's called neuropathy. They sometimes can experience some metallic taste in their mouth, some diarrhea. So by and large, if you are concerned about some of those things, definitely speak with your physician to understand what things to look out for and maybe some preventive measures that you may be able to take to help mitigate some of these side effects.
And I think this is a good question. Does a colonoscopy check for anal cancer?
Colonoscopy is not the best in checking for anal cancer. Anal cancer happens around the anus, or basically the external opening, up to just a little bit on the inside, maybe a maximum of 2 centimeters inside. And so the camera that's utilized for the colonoscopy does not visualize that area as well. Typically, anal cancer can be identified or treated on an in-office exam.
Okay, and what is the starting age for screening for anal cancer? Is there a recommended age?
There's no dedicated recommended age. A lot of it really just depends on certain risk factors. So patients who, women who have had aggressive cervical disease, so with abnormal pap smears associated with HPV, if they've had cervical cancer, certain patients who maybe have immune suppression due to chemotherapy for other reasons, and they develop skin cancers in general. Anal cancer is a form of skin cancer in that area. So those are patients who are going to be at risk. Patients who are HIV positive, patients who are on immune suppression therapy because of transplants, or HIV positive persons. These are all people that are at increased risk, but there's no standard screening age for anal cancer.
Okay, and speaking of risk factors, is there an association? Do race or ethnicity have anything to do with colon or anal cancer?
So 2 years ago, the American Cancer Society changed their recommendations for colonoscopy screening from everyone from initially age 50 to 45. But during that time frame, even when for most people it was age 50, the recommended age for African Americans was 45. And that was because polyps were seen to be found a little bit sooner in African American populations, and sometimes tumors found to be more aggressive. There's no direct genetic link that we've been able to identify as of yet, and so starting the earlier screening, we believed has helped with that. And so at this time, it's still for all comers age 45, and there's no change to age 40, for example, for other ethnic groups. But I think one of the biggest keys for any community is for that conversation where if anyone in the family is diagnosed with either a polyp or a cancer, that's discussed so that the remainder of the family can be tested at an appropriate time, which may be earlier.
And by polyp or any cancer, you mean any cancer, not specifically colorectal or anal, any cancer?
There are certain cancers, if they are prevalent in the family, if there's a prevalence of many people, many women with breast cancers, or if you find multiple different cancers in a family, thyroid plus breast plus ovarian or kidney cancer, sometimes those are indicators of a certain genetic syndrome in the family. So that's a reason to discuss with your primary care physician whether or not genetic counseling should be done, genetic testing for the family, so the family can truly understand what cancers that they are all at risk for and at what age screening for those various cancers should start.
Okay, so it sounds like communication is key.
Yes.
This goes a little bit back to one of the earlier slides. Are any foods or a certain diet associated with colon cancer, or do certain foods minimize risk?
So it's generally believed that foods that are diets that are high in fat and red meat could contribute. There's no direct link to the amount or the severity. There's also indications that foods that are rich in fiber and antioxidants help. Fiber is actually a good colon fuel. So things, your fruits and your vegetables and drinking plenty of fluids and just maintaining an overall healthy, balanced diet are key to help prevent colon cancer.
Okay, great. And I will do a plug. Cancer Support Community Atlanta does do a monthly nutrition seminar, which is facilitated by an oncology nutrition dietitian with Northside Hospital Cancer Institute. So if you have any nutrition questions, please feel free to join us for this month's program. Another question came through. What do you think of a colonic routine cleanse as a preventative measure?
So in general, and this is just my personal preference as a colorectal surgeon, I am not a fan of colonics. What that can do is disrupt the natural balance in the colon. We have good and bad bacteria that live in the colon, and the good bacteria actually can break down the undigestible fiber in your diet to the actual food and fuel for your colon cells. And so just like in sometimes when patients take antibiotics, they can get diarrhea or they can get a colon infection because the bad bacteria have been allowed to thrive. If routine colonics can lead to diminishing the good colonic bacteria that are there, which are designed to help create that good colon health. And then over time, patients can become reliant upon the colonic. And so my recommendation is to flush from above with a healthy diet, plenty of fruits and vegetables, plenty of water, avoiding excessive red meat, excessive fat.
Okay, great. Good to know. And I think we have just a couple more questions. What could it mean to have fecal matter leaking from your rectum? And
so fecal incontinence is a very complex issue. It really depends on whether or not this is pre-treatment or post-treatment. For example, in women who have bore several children and may have had complications with delivery, they can sometimes experience issues with related to a leakage of stool. And so that would be a very personalized question to have with your physician, because there's so many different components to that would have to be investigated to truly understand if there's something of concern with regard to cancer, or whether or not it's even just related to your bowel habits.
Okay, and I think the last question we'll close up with is, do you know if hospitals are still offering screening or colonoscopies during COVID-19?
Yes, definitely. Health and life does go on throughout COVID. There are several measures that are being taken to protect patients and their families during this time. So by all means, do not let your personal health be delayed by the virus. Talk with your primary care physician. You know, sometimes if you're just too uncomfortable to go into the medical facility, this is a time where some of those at-home tests can play a role to really understand what your risk is. But by all means, people should still be getting screened during this time frame.
All right, that's great. And thank you, Dr. King-Mullins. Do you have any final thoughts you'd like to wrap up with?
My biggest thing is, I think, my biggest push is usually discussions within the family. I think that's a big area of helping each other and getting diagnosed that we do miss. And so don't be embarrassed if you have a certain situation going on, if you have certain symptoms or anything, discuss it with your family. Understand if you need to be screened, and that helps you understand who else in your family needs to be screened and when.
All right, and I think with that, we'll go ahead and wrap up. I want to thank you, Dr. King-Mullins, for being so generous with your time and your expertise today. I want to remind everyone one last time that Cancer Support Community Atlanta does offer a monthly colorectal cancer support group along with a monthly family and friends group. For more information on these programs or other live and recorded programs, we invite you to visit our website, cscatlanta.org.
Thanks for having me. Everybody have a good afternoon.
Thank you for joining Cancer Support Community Atlanta for this program. If you're interested in other live or recorded programs, please visit the online program tab of our website, cscatlanta.org, or follow us on Facebook. We'll be sharing additional information on upcoming programs.